I'm taking the privilege to welcome Ms. Deepa Jose for today's session. Saying about her, Deepa is my colleague and she is presently working as the coordinator of the social engagement department in Talim, India. She's completed her MSW in medical and psychiatry specialization from Bharathidasan University, Trichy. Following which, she worked as a project coordinator, gender resource project community field in Delhi for 3 years. She then continued to work with the Banyan Chennai as coordinator for 4 years. And then she also has experience of working as field coordinator with WSC for 1 year in Ernakulam. She also worked at the Saki One Stop Center Alapura as a psychosocial counselor for 1 year. So she is carrying with her a vivid experience, and I do hope that her experience is much useful in discussing today's topic as well as case presentation. So without much delay, I invite Ms. Deepa Jose warmly to walk us through the session. Deepa, it is over to you.
Thank you, Sri Priyachi. Yeah. Am I audible? Hello, everyone. Am I audible?
Yes.
Yes. Okay, thank you. So last time we had a session on communication, and continuingly we will be having communicating bad news and collusion, how to communicate all this. So when we hear the term bad news, so we have only 40 minutes, so I think we could start with the topic. And when the term bad news comes to us in a clinical setting, it will be a very difficult term that cannot digest in for hours or days. So we'll be thinking like, what is bad news? And what is the bad news that doctor want to convey? And from our part, it will be the most difficult part, like how to communicate it. If a patient is diagnosed with so-and-so illness, and especially they are going to attend the EOL, end of life stage, it will be really difficult for the professionals or clinicians to say, to communicate it to the patient and to the family. So in our sessions, we must have certain techniques to handle this issue. So moving to the slide. So this is a condition where a 38 years girl with investigated recently with some illness, especially breast cancer or something related to that. And it is like, how will we say, how will we convey this diagnosis to her? There might be reports, investigation reports with her in her hand, and we have seen that, and it is like, you seem to have cancer. So it is like a situation where there is no hope. The patient might feel like, no future, my future ends here. The feeling started from then, after getting the reports. So now she is expecting the clinicians to move further. What is it? And which stage I am? And there are so many things related to that. whether I should go for work, what are all the diets I have to follow. There are so many questions coming in. So, as I said, it is a situation of hopelessness. It is also a threat to the psychological and physical well-being of the patient. They started thinking about the future. Who will take care of my family? What is my role? And after knowing this, what will be there in the scenario, in the family? So there are so many questions that affects their psychological and physical well-being. And it is affecting their lifestyle. Whether they are, like depending mostly in today's generation, we could see that most of them are depending on the food from outside. So do I have to continue it or not? Do I have to, leave all those habits, those junk foods, or questions will be like that. And their dressing, their appearance, physical appearance, what will happen if it is cancer? What will happen? Mostly they will be thinking like, I'll be losing my hairs. I may become fat. So that shape, food, so many things that comes to their mind. It is also to not to choose or to choose. And there are reduced options, whether to have it or not. So there are so many things coming, so many limitations, restrictions coming to their life. So in this fact, we will also be thinking that whether to tell him or not. We'll be thinking like, oh, she's looking good now, and why do we want to convey all this? And why do we want to, make her hopeless? So there are so many questions will be coming to our mind. So to tell or not to tell is a fact. There are certain situations when family ask us whether we should say it or not. Because they also doesn't want to see their loved one's face in a bad mode. They want to see them happier and the happiest. And they will be asking us, should I tell or should you do this? Even if we do this, what will happen? There are so many things. They'll be thinking like they will not be able to cope with the life. And they will not be able to bear it. They might commit suicide. There's so many questions. So by considering all these, we also have to think that it is a protective factor among family members. It shows us a protection. It is an act of love, actually, an act of protection. So whether to tell it or not, he will be completely broken down if he knows that he has cancer. So we lose that person, that personality, and that factor. So there are these questions coming up when they think that the patient will break down. So it is a protective factor, actually. And we are going to the importance of telling this truth. Most probably, we'll be thinking like, oh, they have cancer and or any other lifestyle, other disease that is threatening to their life. We'll be thinking that, oh, they shouldn't know. But the fact is that it is not like that. They have the right to know, actually. Then only, there are so many things can happen in further. By considering the family's protective factor, we cannot just say that we cannot disclose it. So it is a right for the person to know what he or she is going through. It might help the family to plan or cope with the situation, and also with the patient. They might have so many things to plan for future. Recently in our hospital, we had an EOL patient, and they were supposed to celebrate their wedding anniversary in a week. But when we came to know that, oh, this patient has this, thinking that they have to celebrate. But we know the fact that he's about to die. So these facts, generating them, they must know before their death, like they have to celebrate it. They have to plan so many things. Not only celebrations. Someone might be thinking that I have to forgive to someone. And this is a chance for them to speak to that person. And there are so many wishes they have. Their interest to go out to see a relative, or to some places, or writing a will. There are so many things related to someone's life. So it is important to tell the truth, to plan them better, and to cope with the situation. It is also to avoid false hope. The first thing we must have in our mind that without communicating the fact of the illness, it is like we are giving a false hope for their future, their prognosis. They might think that they may not be aware, their insight towards prognosis might be poor. So by not telling them about the fact, it is also like giving them a false hope of living more. And it will also help to have a good bonding between the physician and the patient. The trust develops. When we speak, when we tell them about the illness step by step, it will help to have a good relationship with. And they will also cooperate with the treatment. They will be asking us, why should I do this? Because I don't have anything. So why do I have to go for a chemotherapy? Or why do I have to take all these medicines? These medicines are this much costlier, or these are the prescriptions, and why should I take all this? Or there are so many treatment techniques that must follow. So their cooperation is necessary. And when we communicate to them properly, to make them cooperate with the treatment. And the next question is, how do we know who can take it and who cannot? There are certain people who cannot take the fact, and there are some who could take it. So in this context, it is not about telling or not telling. It is about how we communicate it. The way of communicating a bad news is really important. So before going to that, from a famous British doctor, and he is saying, I don't know what to say. And in this context, he is saying, learning communication skills bridges the communication gap, makes the pain easy to bear. So if we communicate it in a better way, it will be easy to bear. They will not feel heavy after, a discussion with the doctor. They might feel free. Oh, I have this. By holding the reports and after a good communication from the doctor or from the nurse, he feel that, okay, now I am free. I have this. So a kind of acceptance occur. So there are 6 steps. We call the spikes. So there are 6 steps of protocol in communicating this bad news. So the first one is setting the scene. That is like getting started. Patient's perception. It is about what does the patient know. We'll come to that later. So the spikes are setting the scene, patient's perception, inviting the patient to communication, and our knowledge about the disease, emotions, and summarizing. So setting the scene. It is about plan what you will say. You must have a good plan. In the plans, you must have the medical facts, confirmed facts, the confirmed diagnosis, and the questions. You must anticipate what are all the questions they might ask. Be prepared for that. And you must also have knowledge of the prognosis. We should ask them, we should ask the family as well as the patient that whether they insightful about diagnosis, prognosis, and what are in what level. The prognosis is, they might know like, oh, I have to take treatment for these many years. They might be knowing just that. So we must prepare ourselves before disclosing all these things. See, we must know how will be the future of that patient and what are all the treatments they should go through and what stage they are, how long they live. Or that might be difficult, but according to the stage, we could do it. Also, the medications and other treatments, they must have to go. And the next is maintain a private environment. We might be seeing that in the corridors of the hospitals, they speak about illness, their prognosis and all that. That is not the right place. We must have a private environment, a private room for disclosing all these factors. So it is also to assure that they ventilate all the worries. They ask In a corridor, they might not be able to ask more. So in a private room, they are free to ask. So plan properly that what are all the factors that you have to communicate. Be good with the diagnosis and with the prognosis. In the next step, that is patient's perception about what does the patient know. It is necessary to ask whether they have proper information or they have mistaken it. So what is it? What they know about it? What did the doctor that is seeing your, that is treating your cancer, what are all their sayings, and have you understood it? Listen to them properly, what they are saying. And on the next part is inviting the patient. We are inviting, asking that how much they want to know from us. They might have heard certain clinical terms that might be new for them. So we must be asking them, like, what do you want to know? This is something you have. And what furtherly, what do you want to know? And do you know your disease? What is the prognosis? What is your plan? Patient may say, like, it is enough. Now I have come to you to relieve my pain. And I do not wish to know. They might say, because there's a concept that people think that referring to a palliative care medicine is like they are near to their end of life. So the doctors have the cancer treatment has about to stop, and they now should move to pain management. So from that hospital to this hospital, in between they think that, oh, my life is going to get over. It is not solely the pain. So I do not wish to know. I don't want to know anything else, because it is done. My life is about done, and this is my last stage. So I just want to see the pain. That's it. Nothing else. And at times we cannot push them to us. We cannot, give them more information. And just give them that, okay, we will take care of it. We will take care of your pain. So this is what we could say. We cannot just push them. We cannot trust the information. We are not going to give them more. So we will just say, okay, we will take care of it. We'll take care of your pain. And by knowing how much does the patient want to know, some may say that, I want to know more. Please tell me. So there you have to say, it is the next step actually. By getting all this information, we go to the next step, which is sharing this information, sharing this bad news. We know that how much they know about their illness. So from there, slowly we will start saying that, giving them a warning shot. It's like, yeah, there is something serious in this. Take a pause. see what is their response, and then slowly see the news, which is their diagnosis. Pause in between to make sure that whether they are able to take it or not. So some examples shown in the this that it looks like what you have is not the usual. It's an ordinary. It's not an ordinary thing. It's a kind of wound. It's a swelling, but it's not usual one. And then slowly say what you have is something that might be difficult to cure, or that is difficult to operate, not possible to operate. So these are the warning shots. So from there itself, they understood that there is something and it is difficult to treat. So in this way, you could give them a warning shot. And after giving the warning shot, start saying about the diagnosis. Stop in between, give them a time to take it, to ventilate if they want to something. Just acknowledge what they are going through. And please do not use medical terms, because in the last review, they might have heard all these medical jargons. So they don't want to know all these things. And we are not going to treat a person who's well aware about all these things. We might have illiterates, those who are not even heard of these terms, not even been to hospitals. So please avoid your medical terms. Tell them freely what it is, a growth or a shadow in the skin, which is quite disturbing, which is quite serious. And then slowly what it is, and to a biopsy, in a biopsy report, what is it shown? So further levels of investigation, how was it going? And what are all the things that came up in all the investigations? So slowly tell them. And that is the difference in palliative care. It is not directly we are saying that you have cancer, you have only 3 days left. So it's just 2 or 3 minutes, they finish their thing and they will go off. So here, it is not like that. It is to tell them slowly that what they are undergoing. So avoid medical terms. Check for understanding. See whether they are understanding it or not. Sometimes we don't have to ask them. We might feel like, oh, they understood. Their expressions. Watch all those. Keep silence in between. What's the body language? Avoid monologue. Promote dialogue. We don't have to explain it like when they are not ready. We could understand. We will be understanding them by their postures, their reflections, their response, that they understood or not. So we don't have to have long discussions regarding this. So ask them more. Like, is it okay for you? Like, whether I should continue or not? So see how they respond. It comes here, like their emotion, responding to the reaction. Give them time to react. we shouldn't be hurry on all these things. We must be waiting, listening them, and listen quietly, attentively, allow them to ventilate their feelings. At times we have to use nonverbal communication. And we must have a good observation. We must be observing them well to understand that whether they take it or not. So ask them, make it as a dialogue. So ask them that what are your feelings after what I've just told you? Are you able to follow it? Do you understand it? So acknowledge the feelings. Tell them, I see you are very upset. Or some might be like they throw tantrums. It might happen with the patient and with the family as well. So from us, they came in a blank mind, and from us they might be knowing all these facts apart from the medical terms. They knowing it very well now. So they might develop anger. Oh, why the doctor didn't say anything about it? I should have done this, that. And someone's like, oh, I cannot take it. And what do I do? My future, my children, their marriage, their property, will, all those. There are so many things. My routine, my lifestyle, everything. So some might be upset, and some might be anger. And acknowledge all these facts. We listen to them and acknowledge all these facts. And we must expect it actually. Before in the planning level itself, we must make our mind that we are going to experience all these things. So while disclosing the prognosis, we must plan that, okay, they might get angry. How will we see the situation? Whether I have to, have another family member with them. So plan it accordingly. Or I should take the help of another doctor or nurse or social worker or psychologist. So just plan it. And when they are angry, it is not about, giving them back an answer. It's just to accept it. Acknowledge that is a feeling after hearing something that's not common, something very serious to their life. So acknowledge all the facts. And then while summarizing it, plan well and follow it. Tell them what we are going to do for the next step. As if they needed any additional information or any tests that should be done. So just tell them that what is what is our plan in this. And if any referral is needed, so we might feel like, okay, we should also consult with someone else before administering this medicine, palliative care medicine. So we must have a referral of someone else, and they're treating the symptoms. So we have to plan all these things and ask them whether they need any additional information, or if we want them to do any tests, so we can tell them as well. And then tell them about explain about the potential sources of support. What are all the supporting systems? It might be from a clinical part, from a socio-economic part, psychological part. So what are all the sources, potential sources to support this patient? So we have to plan it and tell them that our availability and the continuity of care. How do we proceed with this treatment? And based on that, give them a hope that, okay, your pain will be managed in this way. This is what we are going to do. So tell them step by step that what are all the things that we have going to do. And if you have anything to plan it properly. And if necessary, you could take the help of your doctor or someone else who is also engaged in this field. So you can refer them with this. So so there are certain techniques that we can use for breaking this bad news. There are some certain basic manners, and use the skill of your counseling or skill of having good communication. As in the previous communication part, you might have all gone through the skills. So use all those skills in this communication. Sitting and greeting, saying them what you are, what are you here in this setting, and have all the courtesies and politeness. Then maintain an eye level. If they are standing, please ask them to sit, or if they are not ready to do, please stand with them and tell them this is the thing. Slowly, you can bring them to your conversation. They might be like, okay, tell me, I want to rush, I want to go, I don't want to be here, and all those. So be on your eye level. So that shows that there is no barrier in between. And they are ready to listen to us. They are, it's not like an authoritative person. They are sitting and they are asking us to sit. It's not like that. So they feel comfort when you be on their eye level, and give them a relaxed posture instead of if we are worried about communicating it will be very difficult, and then they'll be saying us that don't worry, I will manage. So there are situations. So be ready and be in a relaxed posture. And as in the communication sessions, you have learned that lean forward. It is to show that you are listening to them. If you are sitting in the backward, it will be like, oh, you say, I'll listen. So that is kind of gesture we are giving. So lean forward and tell them that they feel like, okay, they are ready to listen to us. Communicating bad news. How can we reduce the unpleasant experience? So preparation and general honesty. Be honest to your communication. Prepare well. And that clear language and pauses in between. Now, whenever you need to have a pause, you must stop there and listen to them. Acknowledge their feelings, their emotions. So for that, you have to pause in between. Do not trust unasked information. Don't give them any explanation or don't give them any more information rather than they have asked. Give them time to sink in with the information that you have given. Give them appropriate hope and the availability of treatment at your center. It's appropriate hope. It's not that we are giving a false hope. We are giving an appropriate hope. We'll be saying that, we'll be explaining to them that what is palliative care and what are all the steps we follow and what are the type of clinical treatments that is available in the setting. If someone is asking for emergency services and ICU facilities, it might not be possible for us. We might be having only clinicians who are specialized in palliative care. We might not have emergency doctors here and ICUs. All those things we might not have. So tell them clearly that if something is going to happen, we are not adequate or equipped enough to take care of all that. We have to rush to the hospital if anything's emergency occurs. And tell them this is the palliative care treatment that we give, and this is the settings, these are the equipments we have, this is the medicines we have, we only treat this. And offer continuity of care. Tell them that we will be seeing them once in 15 days or 10 days, whatever you are deciding for. You assure them that you could call us or you can come to this. Assure your continuity of care, because they have come from the cancer center or wherever, with a feeling that, oh, this I have nothing else to do. So their hope ends, and here a new hope starts. So give them appropriate hope and the continuity of your treatment. Then other clinical situations where bad news may have to be conveyed. There are situations that we must convey. What are all those? It might be to the patient or to the caregiver. By, it might be like the progress of disease. It has developed to cancer metastasis. So it might be like the progress. So what is the prognosis now? And I mean, what is the prognosis? So how would progress? So we feel like, okay, it should be conveyed with the caregiver or to the patient to make them cooperate with the treatment. And especially, or when patient is in advanced stage of, we must tell them that this is the stage and they have these many days left. If they have any wishes, if they have anything to do, anything in their mind, it's time for that. So to the caregiver as well as to the patient, both might have. Patient might have expectations and the caregiver as well. So ask them, tell them, it is necessary to tell that if they are in an advanced stage. And in a terminal condition or at the end of life. So these are the three stages when we have to communicate it. And how will we do it? Do it effectively by asking them. Ask the patient as well as the caregiver that whether I should say it or not. This is the condition. We have reached till prognosis. By posing, we told them that this is the diagnosis you have. from a small shadow or from a small growth, you have reached to this, you have reached to this, now the situation is this. And tell them that, should I move further? Because it might happen. This might happen, something unexpected might happen. So ask them. Taking the cue from the patient by observing them. Okay, I'm ready. They might say that. They might nod their head. They might come forward. So, and by understanding that, by acknowledging these emotions and their empathetic response, not, they are in a sympathetic stage when we cannot disclose it. They are like in an empathetic response, like, okay, I'm ready to know. Tell me. So see their emotions and start telling them. So in summary, it is setting the scene, like getting started. And patient's perception. What does the patient know? Inviting the patient that, how much they want to know, to see whether they are ready to know, and how much they want to know. Oh, they say, no, I don't want to know further. This is enough. There are people, they might say like that. So do not trust, do not give them more. If they're okay with what they learn, what they have heard till then, okay, that is enough. And knowledge of his disease, sharing the information, emotions, responding to patients and families' feelings, acknowledging it, and giving them, a time to ventilate. Listen to them, acknowledge their feelings, observe them, and then summarize what should we do. This is our plan, and this is the follow-up plan we have. So this is in summary. So next is, what is the importance of attempting to breaking the bad news? First one is, like, patient has the right to know. It is not that they shouldn't. It is that the person should know. That is their right, what they are going through. If we are not telling them, it is harming them more than doing good. And we cannot force it. Do not tell if he or she doesn't want to know. If they doesn't want to know, okay, just leave it like that. Slowly, we could develop to it. And as I said, saying it or not saying it is not the issue. How will you communicate it? And that is the important part. So this is about communicating bad news. If you have any doubts, we can clear it in 2 minutes. Or you can use the chat box as well.
If we don't have any pressing questions, I think we can move on to the next part, pollution, and then take up the case presentation.
So there is really a thank you. So I think we could move to collusion as well. Thanks. Was it clear to everyone?
Yes, ma'am.
Okay, thank you. So, shall we move to collusion then? Sorry, thank you coming in the chat box. So, I think we could move to collusion as well. So, okay. So, the next part is collusion. So, can anyone say what is collusion? And it is familiar, right? It is familiar in clinical setting with colluding a fact. So, can anyone say that what is collusion is? No idea. Don't know. Okay. So, as in the screen, it is to act together secretly to deceive someone. To collude is like we in a palliative care settings, we will mark collusion, which is positive or not. I mean negative. We want to hide an information from the patient or not. And it is applicable for the caregiver as well. The patient might not want to disclose it to their family members. So there is collusion positive. Collusion is positive towards the family members. And in another scenario, it is just opposite, that the family members doesn't want to communicate it to the patient. So it is simple that we are hiding an information from either from the patient or from the caregiver. So we will mark it in the registration form or wherever it is. It is easy for the doctor or the nurse or the social worker or the psychologist to understand that, okay, there is a collusion. That whether it is to the family or to the patient. So we are not disclosing the diagnosis or the prognosis part to the particular person or to the family member. So it will help us when if it is noted in the registration form. Whenever we take the file, we feel like, okay, I shouldn't disclose it because it is because of so and so factors. Though it is a right for the patient, right to the patient that they should know the fact, they should know the diagnosis or prognosis. At times, due to family insist or the otherwise, that we should hide it from the person. There are many times we have to do this. So we will mark that there is a collusion. And about what? People might know that, okay, they have, my father has cancer. But only the father might be knowing that he is in the third stage or a fourth stage. And he doesn't want to communicate it to the other family members. So there, collusion is positive for diagnosis for the family members. Whereas the prognosis factor whether she's in a third stage or a fourth stage. Thank you. The prognosis factor that they he might have to hide it from the family members. So there, the collusion is positive for prognosis for the family members, or it might be vice versa. The patient know that he has cancer and he doesn't know the prognosis, because the protecting factor, the protecting act by the family members, they think that, oh, if he knows that he's in this stage, he is not going to survive. He is going to commit suicide. He'll completely broken down. So these factors, these protective acts, stop them. Factors stop them, colluding these prognosis to the patient. So we will mention that collusion positive for prognosis for the patient. So collusion is hiding a fact to act together in a secret way that only the clinician or whoever seeing the file and the particular person who knows about it. So it's an act of keeping a secret. Is it you understood? I mean, all of you have got this, what collusion is? Okay. So a secret agreement, especially in order to do something dishonest. So when we say that we have to be honest enough, but at times we have to be dishonest in the faults from the family or from the patient. They they might be keep on saying that no, you shouldn't family members, the complete family structure will be broken. So I don't want to see that. So please don't tell anyone. I will suffer it myself. So please don't tell them. So that's a secret agreement between patient and the clinician, or with the caregivers, with the doctor or the nurse, whoever the person treating them. It's a non-competitive, secret, and sometimes illegal agreement between drivers, which attempts to disturb the market's equilibrium. The two companies had colluded the fixed prices. So it's a kind of example there. So generally, it denotes deceit or trickery rather than good-natured fun. Okay. So in more ways, it is hiding, not telling the truth to the patient, doctor not revealing. So in our society, we mostly seen that family is someone who comes forward saying that please don't tell them, tell him, or please don't tell her about this illness. So family, they, even if someone comes forward, the other family members, they say that no, don't tell them, don't tell him. He's a very happy person, so we don't want to see him broken. So don't tell them. There are cultural differences. Like in Western society, patient colludes from family. Patient is like, okay, I will handle it. Don't tell my family. So there are differences. And though this is the thing, that collusion is something that hiding the information. Why? Why they they don't want to tell. In the fact that it is an act of love or a need to protect another from pain. Their psychological suffering. First thing they will be the first fact that is coming to their mind might be like they will be psychologically depressed. We cannot see that. So it's a kind of acting love, care. That is something to protect them, to not become emotionally weak or psychologically weak. So what are the harms that collusion can do? First might be the relatives, they believe. It's a false belief actually. So they feel like patient doesn't know the diagnosis, even though they have been taken to so many hospitals, so many investigations, reports, they have all the reports, they are taking all the medicines. They think that even though the patient doesn't know what exactly it is, though he might be knowing that he has some illness, but it is not yet clear. So the family members will be thinking that, oh, he doesn't know. He, even though he has, all these medicines with him, have taken to this many hospitals, he doesn't know the diagnosis. It's actually a false belief. Because did any of us will go to the hospitals like this? No. If there is something serious today, we'll be having regular visits, much of test reports. So it is a fact that the relatives have this false belief that the patient is not aware of his illness. He somehow know what is happening, or by reading the medicine strips or the prescription, or by seeing the boards. He might know. He might not be sure about the diagnosis, but he knows that he's undergoing something, and that is serious. And the family think that he will give up or die if they disclose the fact. If it is also a false belief. The family, by doing this, it is not making them die physically. It is making them psychologically weak actually. Will be unable to, people think that he will not be able to cope with the situation. He will fall. And, that is, we cannot suffer. We cannot take it if he falls, if he dies. And another thinking is the responsibility to shield their loved one. It is a kind of shield they are building. A kind of responsibility. They are taking it as a responsibility. And in another way, the protection may actually cause harm. It might cause isolation. The patient is somewhere and the family members together, they whisper, they murmur, the patient is observing all these things. Though, we'll be like, okay, he's in another room, we will discuss about it. He is actually observing all this. After hospital visit, if you see, the patient will not be, sitting in one place. He will be roaming around to see what are the talks in the family? What are they talking about? So he might be roaming around to see what is happening, that we might know. And she will also feel like, oh, I'm isolated now because they are making a group. What is going on? So they'll have a sense of isolation and a sense of worthlessness. Oh, they are not taking me to this place, and they are asking me to not to go for not to go for job or to the school, to college, or to a far place, saying that okay, you are not allowed to travel, you take rest. So these are some words that we use, right? That you take rest. You cannot walk long. You cannot travel long. You cannot continuously go to work. You can have a digital classroom here instead of going to the school. So there are so many things that unknowingly we say that makes that person worthless. And based on that, there are certain bad effects of colluding it. That is obviously never being able to be honest. If you are hiding something, it just, of course, the patient will feel that no, he is not honest. He is not saying what I'm actually going through. And when the time goes, there is that isolation, that feeling of isolation has increased. That level of feeling is being increased. And obviously, we could see that family prevent visitors. And some selective persons could call or could come with saying that, okay, it will affect the health of my dear one. So it is a kind of isolation that the family members are making. Anger. Everyone knows. He feels like, oh, everyone knows. They are gathering here and there. They know everything, but nobody is telling me. It might lead to, by step, it leads to a chronic anger outburst. It might lead to that. It's not might, it will definitely. And then giving a false hope, lack of trust, more emotional distress. So a false hope in a stage of their life, they come to know that, okay, they were giving a false hope till now. So what will be the reaction? You cannot expect it, right? And lack of trust, they will not trust them. Definitely, he or she will not be trusting the family members. He'll be saying that they are hiding everything from me. I know that they are, having some discussions. They are not accompanying me. So definitely, he or she will lose the trust, and it will lead to more emotional distress. Unfinished business, blocked grief, depression. All these things happen. Why? Suicidal tendencies. Then disturbed patterns of sleep, eating difficulties. All those things will happen. And when the time goes. And there are all the points that we should remember. Is mentally competent adults have a right to make decisions about their own care. If it is a child, okay, we can to a certain extent we can accept that, okay, it is okay to collude. But For adult, it is their right to make decisions about their own care, whether to have this treatment or not, whether to cut my hairs or not, whether to shave it, whether I should wear this kind of clothes, I should take a particular diet. So there are so many factors that they should. And it is also unethical to keep the truth, right? It is against the ethics, actually. If they are willing to take it, let them know what is happening with them, the level of prognosis. It's not only the diagnosis, it is also the level of prognosis. And in another way, when the family says, don't say, how are we going to react? Even though we know that this is not ethical, that we shouldn't, or it is the right of that person. There are two factors, right? Ethics and the right. So these are the factors we must consider. So how will we respond to it? So when family says, don't say, acknowledge their concerns. In a situation that we must acknowledge it, we will be saying that, okay, I could see that you're worried about this, because they know the patient than us. So what will happen to him in the next stage, we might not know. So even if you say that, okay, this is the right, okay, I should tell him directly. No, it will not work always. So we must speak to the family. If it is colluding from the patient, we must speak to our secret agreement. Whether it is with the family, then we must talk to them first, and we must understand why we shouldn't, why we should collude. Or if it is the patient, we must talk to the patient that why you are asking me to not to tell it to the family. What are all the reasons? First, acknowledge their concerns. We must acknowledge it, and then only we can have a good treatment. Explain benefits of telling. Just tell them what are all the benefits. It might be, good cooperation in the treatment, good cooperative mentality for the treatment. And sometimes they might feel like, okay, why I'm having this? Because I have nothing. I have a small illness or something. I have just I have a fever or just a growth. Oh, that can be removed. So why am I having this kind of treatments? And at times it may be like, a will to write down. You want to transfer their property to someone else's name, or as I said before, they might be, have to forgive to someone or reunite someone with someone, or to, hug their, or to see their grandchild, or to see their child to get married. There are so many factors. There are so many benefits. And if they acknowledge if the patient or the whoever has been colluded with, they know that, okay, I have this. So before I die, I have to do certain things. So they come to a conclusion that I have to do all these things, and I have to agree for this treatment, which is good for me. taking a tablet may not be enough for my pain because I have these many issues. So there are so many things, though, so many benefits by telling them. And of course, as I said, the patient has, or the family even, has the right to know. Patient, especially patient, has the right to know what is happening in their body, what they are going through. So they have the right to know. And at times, we might have to ask them, do you think that he suspects that there is something happening with them? Or do you think that which level they are, or whether they are suspecting? So by your acts, whether they have any doubts. And also, how does it make you feel by not telling them? What is, how is it making you feel like? So there are so many things. Explain the possible harmful effects of not telling them. What are the harmful effects? And we must explain them these things as well. And as like I said, acknowledge what they say. So in summary, collusion is something that is hiding the truth, and family colludes to protect their loved one. It's an act of protection, as I said. So then it may do more harm than good, as I said. It false hope. They might get a worse level of anger, a worsened level of isolation. So these effects result into all this. And before breaking the bad news, we must handle the collusion. Then only we should understand that whether we should tell him the fact or not. And acknowledge the family's concerns. As you might have known that what are all the communication, for good communication, what are all the steps you have to follow? You have learned in the last session. And also, like certain of you have been gone through counseling techniques and all. So use all that empathy, planning, sitting and using a private room. All those techniques you have to use. And of course, accept if family is obstinate. Keep the door open. If they are saying that, no, you shouldn't until the death. Okay, till, we have to keep our doors open. We will be telling them repeatedly, we will be, saying them what are all the effects that is going to bring to the patient's life. So we must acknowledge all these factors. So by this, ending the presentation. And so if you have any queries, you can use the chat box. We also have a case presentation. So I think.
Thank you, Deepa. Thank you so much for walking us through such a very vast topic. It is a very vast topic and it is very difficult to cover in such a short span of time. But yet, I think, Deepa, you managed very well. Thank you so much. Any pressing questions, any burning queries?
No, ma'am. Thank you, ma'am.
Thank you, Surya. So we will, I think, move on to the case presentation and then come back for the discussion of the topic as well as the case. Today's case is being brought in by Sundaravalli Raman.
Thank you, ma'am.
You can continue.
Okay, my name is Sundaravali from Malaysia, Sunway Medical Center. I'm a staff nurse. Okay, getting my patient. Age is 53, gender is female, diagnosed metastatic colon carcinoma and metastatic mets to liver, lungs, peritoneum, bone, and ovary. Presenting complaints, she came in with abdominal pain and distension, with low back pain and poor oral intake. They required assistance in ACL, lack of nutrition and nausea and vomiting. Her history was medical history, just a colon cancer diagnosed in April 2019, and surgery for rectal resection, post-ileostomy for complete bowel obstruction, ileum and distal small bowel, diverting loop ileostomy, and cystoscopy bilateral retrograde pyelogram plus bilateral stent insertion, and ultrasound guided thorax catheter insertion and drain out 5.2 liter. It's just one time. And then on examination, patient is a bit restless plus visual hallucination. Abdo was soft and tender, pedal edema bilateral, and she has oral thrush and also have rash at her back. And she looks very thin, cachexia, bradycardia on 0.25 liter face mask. This was when she came in. And next, the treatment and significant investigation. The treatment done was surgical intervention, palliative radiation therapy, palliative chemotherapy, and the last was comfort care. Blood investigation done. HP was 8.9, blood count is 26.4, potassium was 6.1, urea is 20.9, creatinine is 931, uric acid is 586, and the liver is 627, CRP is 234. But this patient refused for the dialysis, even though the creatinine is very high. And ultrasound abdo-pelvis right urethric stent is in situ. This one is after she do the stenting. CT abdo, there are multiple heterogenesis, hypodense lesion in both lobes of the liver, suggestive of metastasis. Psychosocial aspects. Okay, patient is married and staying with the husband and two sons. Both are studying, and the financial stress resulting from low income because only the husband is working, and the cost of healthcare, and they want to be treated in the private healthcare because they have from what we understood from them is they have a bit of bad experience in the GH and lack of health insurance, anxiety, depression. Elder son is totally not ready to let her go. And big social support as never visited by the family members or friends while she was in the hospital. Patient's will settles when she was lucid. And in the hospital, they prescribe with oral 7 mouthwash, sodium bicarb to do the oral care, and subcut midazolam 2.5 mg PRN hourly, and subcut fentanyl for pain 25 mcg PRN also for hourly, if necessary PRN, and subcut buscopan for secretion 20 mg PRN hourly, if IV paracetamol for fever 1 gram PDS PRN, subcut haloperidol for hallucination and confusion on night only, IV Piriton 10 mg OD, transdermal fentanyl patch 25 plus 6, total is 31 mcg, duodentic to sacral to prevent sore, and CSCI midazolam 15 mg plus normal saline, mark up to 24 mils, run at 0.6 mils per hour. Main concern was emotional support for patient, for the patient's elder son, and discuss about their financial issues. Like what we do was they request doctors not to visit unless they want. if let's say they have a major problem or she's very restless and they cannot cope, then only they want the doctors to be visited in the ward. And the item which they can purchase, like glove, gowns, and oral sticks, and diapers, and the underpad, those things they buy by themselves, because in the hospital setting, all these quite expensive than the regular charges. So also help them with the best supportive care and our life care, assist patient in ADR. Okay. Summary: patient diagnosed with metastatic colon carcinoma and patient admitted and hoping for further treatment to prolong her life. Her disease was very advanced with high risk for further deterioration in setting of bleeding, sepsis, multiple organ failure, with very guarded prognosis. So patient and husband well accepted. Initially, the husband did not accept, but then towards the end, he accepted. Express goal of care is optimal symptoms to control the comfort, and patient express wish for terminal sedation at terminal phase if need. Preferred place of care is hospital, and she refused for dialysis. In the event sudden deterioration, she would not want to be resuscitated or no intubation and CPR. And our discussion point here is, how do we care for patient who is unable to express themselves as they are slurry at times and confused? And the second one, how do we assist family members to care for dying patient when they are still in denial? Thank you.
Thank you, Sundaravalli. So it's very relevant case for the topic today. But since we are, this case is having many medical aspects as well, but since we are dealing with communicating bad news and handling collusion today, I believe we will just stick on to the points related to that. So, Deepa, maybe we should first ask the participants what
Yes,
they feel.
definitely. How do you people feel that Sundaravalli has expressed that these are the factors are difficult to deal the case. So, us professionals, how will we, or palliative care nurses, how will we dealing all these facts?
Suppose this patient is under your care in your ward, so how will you be?
So, like, madam, if the patient is confused, it's very important to keeping them repeatedly giving the reassurance to them, like confirming the things again and again, so that they are very sure like what is happening around. So that could be one thing for any patient who is confused.
Yeah, here is what we say is like, we shouldn't use any medical jargons or medical terms that is not familiar for them. We must be very clear what we are saying. Step by step, as we said in communication, step by step, it's a step by step process. Tell them what they had and what is the progress of that. If they were having a small growth in the beginning during this date, and till now, what they have progressed to. So that's why we are saying, tell them in a proper manner, be planned enough, know their diagnosis, the prognosis, and we must plan for it as well. So by step by step, if we are saying that, oh, there is a shadow showing in our X-ray, so I doubt that whether it is this or not that. So we will have another set of investigations. So it's a step by step of thing. And then to coming to a tumor, and then biopsy, then saying that, okay, this, and this has this much, spreading, and this is the stage. And what you are going to have next, possibly. So it's a step-by-step process. Then the patient know all these facts, and also we are explaining them what is going to happen in the future. So they till a certain extent they clear about their diagnosis and prognosis. Also, we must also have the family members as well if it is not happening. If it is not possible, we will have the family members as well. Tell them clearly what is he going through. And if possible, at times we could have the help of psychologists to deal the dilemma. If it is traumatic, then have the psychologist as well for further follow-ups.
Sister Sundara, just anxious. You were telling that the elder son was in denial mostly. He was not letting her go. So how old is he? Like the patient is
eldest
53.
21.
21.
Yes.
31.
The patient was passed away a few days back, but until towards the end, the son really
Mhm.
cannot accept that the mom is going.
He's 31, right? 31.
Yes.
21 years old.
21.
Okay.
Yeah.
So that is where I believe the more problem lies, because they are very active for their age. They are much thinking. They are not small kids. So we need to take them into confidence in maybe another way.
And it is their time to depend on something else and want to be independent. So they are just moving out from the family dynamics. That is that age. So suddenly, if they know that they are in 21, so suddenly they are knowing that without being independent or someone that was a backbone for me in this trouble or in this scenario, how will I move on? How will I live without my mother? And that is the main fact in that age. So it is really difficult to make them understand. It takes time to time, even after death also, it is a denial till after that. So
Maybe it will take a couple of counseling rounds by experts who sit with him basically and make him understand that as a son, as maybe her well-wisher, it is his primary duty to ensure that her last days are made comfortable as far as possible. Because even for the mother, I believe it would be stressful to watch when, specifically when you have said that the husband and wife, both of they have accepted the prognosis, and now only the son is in denial. So they might also be finding it really hard to convince their son that okay, the mother, especially when she's already having trouble with this illness, she might be finding it really hard to make the son understand that okay, these are my last days and I want you to understand that. So what is
and
your
also,
suggestion?
and also to take up more responsibilities that I was carrying through. And he also have to see the little one. So there are responsibilities, more responsibilities that is going to happen. So both the factors.
Yeah, maybe that would be the root cause also for his denial, that he is fearsome. When his mother goes away, he might have to take up the responsibility of the father and the other kid in the family. Maybe those might be his fears, that he might lose his freedom somewhere. He might lose his individuality somewhere as a someone just out from the teenagers. So it is better, I think, we explore those possibilities and give him assurance that his individuality, his responsibility is nothing going to be in risk.
Next is, how do we assist family members to care for dying patient when they are still in denial? It is only happen when we, any suggestions for that? For the second part?
Any more points anyone would like to add in there? Just 1 or 2 minutes to go. Can we have all the cameras on, please?
Yes, yes, yes.
Because we have been seeing the blank screens for some time now, and we would like to see at least some
To a
smiley
certain
face.
extent, we could accept that you all might have work and so many things that you cannot turn on.
But
for
almost the session is good to end, so
yeah,
we thought we will end on a good note.
so and I think we too are new to this session, so it is also a chance for us to see all of you.
So any point which any one of you would like to bring in to share with the other learners here? I think the silence says everything.
So
That is the best communication.
Yes, yes. So as we observe that it is also the same fact that from the time of registration onwards, we are having this bad news breaking with the family as well. It's just not only with the patient. So the answer is there in the session itself, that by step, we have to disclose things to the family and to the patient. If we are colluding it from the family, here there is a collusion about the prognosis. So even though he is like, okay, there might be an anger that I cannot accept it, I won't accept it. So it takes time to make him understand and tell them clearly what are all the supports that we could offer and how we could help them. And if it is a dying patient, then what are all the things that family members has to do, and what are all the things that we could do. So tell them clearly what is going to happen. So even though he is denied, to a certain extent, in a certain point of time, he will accept that. And in this, in future session is over or not, in the psychosocial part, we could see that there is a bereavement support. So after the family, after the patient's death, we have support for the family as well. So, it is seeing the family as the family's pain also in the total pain by treating them, visiting them after the death. We offering a bereavement support. And in that support, if still the son is denying, we can have a counseling, psychological counseling. If possible, we could take him to the psychiatrist as well, or to the doctors if it is more necessary, or to the other doctors as well. So
actually, I
yeah.
have a suggestion also. Good
Yeah,
evening to
definitely.
everyone. Maybe when the patient nearing to the terminal phase, so time to time, I think doctors or even the nurses can reiterate the current situation, what the patient is nearing. So to remind them and mentally prepare them for the upcoming.
Yes, yes.
Also, I think another way, and so that they know the changes, because they've been accompanying the patient daily in the room with the patient. So they might see the changes. So it might help to, whenever we reiterate the situation, I think it will help to understand more and more what's going on to the patient situation, maybe the current condition, what I mean.
Yes, yes, definitely. Yeah.
Making them realize that this is the situation and it has been changing like this for the last 2 days. Yes, that will definitely help to keep them reminded that things are moving towards a specific direction. Correct. Thank you so much, Vigneshwari, for that valid point.
Thank you, ma'am.
Georgina has something to say.
Okay, I think if no one has any suggestions for the moment, we can wind up for the day. Thank you everyone for joining in. Yes, you are free to bring in your suggestions, share your suggestions and queries with us over.
Thank you, ma'am.
Thank you so much for everyone for joining in.
Excuse me, please. Can you upload previous lectures into the Moodle?
Yes, it will be done. It will be done.
Yes, we are waiting that because we had the second